In this presentation, we will focus on a very specific point that is quite a difficult point, honestly. That is the use of antipsychotics in depression. We have seen before that indeed antipsychotics are useful in bipolar depression, they are useful in bipolar mania, are useful also in bipolar maintenance. But the question is, what we do, how we use antipsychotics in depression. That is a counterintuitive concept. Starting from the simple part, nobody would ever use haloperidol in depression. If you receive in your office a patient with severe depression, the last thing that you think is 10 milligrams of haloperidol. What's the point? Just worsening depression. And also the guidelines on this are not very clear. This is why I'm making you these two presentations today, because they fill the gap of what is in the guidelines. It's not very clear to get information around, because the guidelines say, okay, antipsychotics may be used maybe as augmentation, that's it. Let's go a little bit more in detail. Antipsychotics in depression, with a focus on the new antipsychotics that are working on it. So let's try to follow our scientific treatment. And antipsychotics, indeed, are so-called antipsychotics, but they are used in many conditions. We will see at the end that there is the new nomenclature that will completely change the way that the drugs are used. Let's focus on those. Okay, again, the Australian and New Zealand guidelines, I like out their pictures. And they say the same thing that they said in bipolar. Depression is complex. Depression is a combination of aspects that we should consider, from evolution, childhood experiences, environmental factors, genetics also here, of course, and neurobiology, because the brain of depressed patients is affected in a different way compared to the brain of bipolar patients. In bipolar, probably there is, you will hear from Benedetti, a problem of communication between areas, like in schizophrenia. Bipolar and schizophrenia are very similar in this sense. In depression, there is more a reduction of the activity of same areas. Prefrontal cortex, hippocampus. And then there is this strange connection with heart functioning and heart diseases that has been confirmed that way. And so we have a very complex clinical picture in depression. And also the treatments of depression must be done in a complete way. Here we are talking about antipsychotics in depression, but we don't talk about only pharmacological treatments, antipsychotics or antidepressants, of course. Also, depression should be treated with a wide range of psychoeducation, psychotherapy, physical activity, food, the microbiome connection with mood and anxiety. So I cannot talk about all this now, but just to remind with one slide that treatment of depression is not only sertraline and that's it. Is a complex treatment, physical, educational, behavioral, and so on. And so these are the actions that one can mention you here from the guidelines that you can find in the paper. Okay, let's go into the topic. I put here the two extremes, I would say. This is quite old, 10 years, 12 years ago. Paper from the American Journal that was questioning the use of antipsychotic drug for depression. They say, oh, be careful. Antipsychotics are dangerous. Metabolic side effects, extrapyramidal side effects. In depression, we can make a big damage. And then there is this other, more recent paper, just this year, that reveals that indeed antipsychotic is very common also in non-psychotic depressed patients. So, of course, psychotic depression, you use antipsychotic. But the surprising point is that clinicians, we use more antipsychotics also in non-psychotic depressed patients. And then, what's the reality? Are antipsychotic bad for depression? Are antipsychotic good for depression? Let's discuss this point with the focus on the new antipsychotic. First, indication. The indication, this is the label of European, American, and similar combination. The first generation typical antipsychotic, usually they are not indicated for depression. No one of them. So this is very clear. None of the old one should be used in depression. But the new one, they have some indication. The oldest one is quetiapine. We discussed before. Quetiapine, 150, 200, 300 is used for depression with a label, so we can prescribe without any issue. Not only in bipolar depression, but also in unipolar depression with partial response. But it's not the only one. There are the new ones, Lurasidone and Cariprazine, and also Brexpiprazole. Brexpiprazole is indicated by FDA as adjunctive treatment in depression. So we will focus in this presentation on these last three, Lurasidone, Cariprazine, and Brexpiprazole, because quetiapine you already. So we have three new antidepressants that have indeed the indication for depression, but depression not bipolar depression, depression unipolar depression. I don't know if you have these three, Lurasidone, Cariprazine, and Brexpiprazole. None of them, but will arrive sooner or later. So it's important that you know in advance what they are. These are from the Maudsley guidelines, another guideline that I suggest you very strongly because they are very well done. Kahneman and Maudsley are the best. That remind you a very simple but useful point. When you prescribe antipsychotics, you are not prescribing self-relief. It's different. So you should always check for a series of blood parameters, ECG, and things. And just to remind us what we should do, there are these very useful tables from the Maudsley. Before and during antipsychotic treatment, monitor this list of things like blood pressure, liver function, and blood. Okay, let's go into the center of the presentation. The new antipsychotics are very interesting because they have a pharmacodynamic profile that is very flexible. They are different from the old haloperidol. Haloperidol was just blocking D2, dopamine D2 in the frontal cortex and also limbic areas. So if you block dopamine D2, you have block of dopamine, lack of motivation, sedative effect, antipsychotic effect, of course, but with a lot of side effects. And the new antipsychotics are extremely more sophisticated. With serotonin 2A, for example, that is balancing the dopamine D2 regulation. But depending on which of these pharmacodynamic targets are present in the compound, you can have many different actions. You can have actually different sedative actions if they go to muscarinic, histaminergic, and alpha adrenergic. You can have the antimatic effect if you go on the dopamine D2 and the 2A blockade. You can have the cardiometabolic actions on the muscarinic, histaminergic, and the 2C. But you can have the antidepressant effect if you have, for example, a partial effect like Antipsychotics and Brexpiprazole and Cariprazine on the dopamine, and if you have an action on the serotonin 2A So, based on which is the pharmacodynamic profile of our compound, we have different actions. This is from the Stahl, another book that I suggest you very strongly to consider for our practice. And they are different. The so-called pines, clozapine, olanzapine, diapine, senapine, they have a lot of serotonergic activity. This is the dopaminergic as a standard, left means more. So more serotonergic than dopaminergic. So they modulate in a delicate way. This is why they are more antidepressants. Why the so-called dose are much more less serotonergic compared to dopaminergic. And therefore they are usually less antidepressant, less useful in terms of antidepressant. And the partial are different because they are more on the detour than on the serotonin, but this is a partial effect, so this compensates. So it's useful to have in mind this subdivision to know what you are prescribing to each patient. The book things are even more complicated because it's not only serotonin 2A and dopamine 2, there is also serotonin 1A that is modulating the antidepressant effect, and the serotonin 1A again is more relevant for the pines, much less for the dose. So this makes very clear the first concept that for antidepressant effect the pines are better, the dose are worse. But this is not the only point. The other point that is quite relevant is the tolerability. In this huge table, also is in the Mosley, but I have it is also in some of my papers and I think also in some of my videos in YouTube channel. Antipsychotics differ a lot in terms of side effects. And so to use this table, when you prescribe them, is very useful. So a patient, for example, has the risk of hypertension, well, we should avoid Cariprazine, clozapine, serpinol, and maybe also diapine and risperidone, low pressure. Or, for example, we don't want akathisia. Be careful about peridol, phenazine. So this is just an example of how we should use those tables that I suggest you very strongly to consider. And consider also the cardiologic profile, the famous QTC prolongation, that everybody is worried about this QTC, but honestly the risk, in my opinion, is not so strong. I've never seen big changes on QTC, and we also published a paper that this worry is largely exaggerated because QTC changes for many other reasons like irritation or electrolytes, but drugs, except if you use haloperidol 100 milligrams a day, is not much dangerous. However, there are tables also for this, no effect. Brexpiprazole, Cariprazine, Lurasidone, no effect, Cariprazole, senapine, and so on. And some have indeed a high effect, but not much used, and moderate effect for haloperidol, diapine, and so on. So these tables are useful as well. Okay, now in the center of this presentation, I would like you to give an overview of this new. We are today discuss new treatments. They are not available in your country, but I think will be available soon. And they are very interesting. We are starting to use them, and so I can tell our experience, and this is literature. These are three new, very interesting drugs. And many will come. We are lucky now. We are in a lucky period because after 20 years where nothing was happening, always the same compound, now a lot of new will come, ketamine or the glutamatergic ones, new antipsychotics. So there are many perspectives. So we are living in very interesting times from this point of view. New antipsychotics for depression. Cariprazine, Brexpiprazole, Lurasidone. Let's discuss it a bit one by one. Cariprazine. Cariprazine is partial agonist, the 2 and the 3. So this already gives us some information. It's partial, like Cariprazole, like Brexpiprazole. So it's not strong in terms of reducing the dopamine D2 effect like haloperidol. So the first take-home message, Cariprazine will not be as effective as haloperidol for reducing the activity of our patients. Good, because we are talking about antidepressant effect here, not a strong antipsychotic. But it's also active on serotonin 2A, antidepressant effect, and partial on 1A, antidepressant effect. And small but some histaminergic, that means a little bit of sedation. So we can imagine the clinical effect of cariprazine from this picture. Let's see the data. We did a paper a couple of years ago with Filippo and Stuart, to focus on what cariprazine what's the place of cariprazine in treatment of depression in general. And we calculated these effects, and the results are very interesting because if you consider the overall antipsychotic effect of cariprazine is less than any other. So I would never suggest to use cariprazine for a very agitated patient, bipolar, manic, or schizophrenic, acute psychotic in emergency room. No, cariprazine is not for that. Because the antipsychotic effect is much better than the haloperidol or Lurasidone or Brexpiprazole. But this is a positive aspect of the point, that not being so strong in sedating our patient, we could use the other pharmacodynamic profile, and in fact, on the negative symptoms, cariprazine is much better compared to many other compounds. If you shift these effects compared with the positive effect, cariprazine on negative symptoms of schizophrenia and on depression, or bipolar, or major depression, would be potentially useful. Let's see something. This is a very interesting paper, not mine this time, that compares the effect of cariprazine 4.5 and risperidone 4. Consider that cariprazine 4.5 is high and risperidone 4 is medium low. And the effect of cariprazine is much better compared to risperidone in all the negative aspects. Blanket effect, emotional withdrawal, poor contact, passive activity, abstract thinking, and so on. Better. And same dose is worse on positive symptoms. Hallucination, less than risperidone. Excitement, less than risperidone. Anxiety, less than risperidone. Even not significant, but less. So even at a high dose, cariprazine is less effective than risperidone at low doses on positive symptoms. It's not made for positive symptoms. But risperidone, that is known to be quite useful for negative symptoms, is worse than cariprazine even at low doses, when dopamine D2 blockage is not so bad. So this study I like a lot because in a very clear way demonstrate which is the personality, I would say, of cariprazine, which is the profile of cariprazine. A delicate antipsychotic that is very useful for negative symptoms, not so much for positive, depending on the patient. What say the Canna, the famous Canna? can suggest cariprazine strongly in acute depression of bipolar, because of the bipolar guidelines are also applicable. But for bipolar, cariprazine is one of the few with full suggestion for depression. Why? Because there are some data around, this is 2016, and indeed, in this case, cariprazine 0.7, 1.5, or 3, more or less, all of them gave a relevant effect compared to placebo in bipolar depression. So in bipolar depression, cariprazine is indeed potentially useful and supported in guidelines, and of course also negative symptoms of schizophrenia. Here we are talking about bipolar. And this was somehow confirmed 3 years later, more or less the same difference. But what's interesting is that if we look at the inadequate response to antidepressants in major depressive disorder, we see that indeed the same difference is there. So cariprazine could be useful not only in negative symptoms of schizophrenia, in bipolar depression, but also in unipolar depression. Strong effect, not strong, but we are talking about 2 points of least square indifference, so a certain effect is there. At a little bit high doses. So for example, we have some patients here that we treat with 2 milligrams. 2 milligrams of cariprazine, usually at the evening, is a good central point, based also on this data. 1 would be too low, 4.5 would be too high. 2 milligrams is good idea. And this is cariprazine. Even if results are not always supportive in this other paper, the effect, the benefit was a little bit less compared to the other, depending on the study. And indeed, the famous essential psychopharmacology suggests use cariprazine mainly for schizophrenia and bipolar disorder, but also for treatment-resistant depression. Okay, this was cariprazine. So I hope that this cariprazine sketch will be useful for you when cariprazine will arrive in your country. Another one will arrive that is interesting, it is Brexpiprazole. We just got it from, I think, less than 1 year in Italy. Brexpiprazole is a very interesting because it's a modification of aripiprazole. Is better or worse? No answer. It's different, depending on the patient. For some patients it could be better, for some patients it could be worse. Let's see in detail. You already know aripiprazole, partial agonist of D2. So, stabilizes at 30% dopamine. That is good for patients that are a little bit depressed. It's good for patients that are manic or mixed or unstable. But brexpiprazole has also more serotonin effect, antidepressant effect, some alpha, and therefore sedative effect, and other serotonin effect. And in practice, what happens in practice? In practice, brexpiprazole tested in schizophrenia, measured the pressure, studied 2 years ago, indeed gave quite clear benefit in depressed population in combination with the antidepressant. Antidepressant and brexpiprazole versus antidepressant and placebo. And the least square mean difference indeed is clinically relevant and also the significance. In the range of 3 milligram, 1 milligram, they tested the different dosages, higher usually with less. So, the theory and that the data suggests that Brexpiprazole could be useful as a combination in major depression, not responding very well to antidepressants alone. Indeed, they did a meta-analysis, and what's very surprising is that all the studies, all the doses are better than placebo. So there is no uncertainty here. 2 milligrams per day, 2, 3, 1, 3. All of them show an effect size that is not trivial, 0.5, 0.4 or something, better than placebo. So take home message, you can use Brexpiprazole in combination with the antidepressant when the antidepressant effect is not very relevant. In this paper, last year or so, I made a point. This is open access. I think we can take our release from the internet, also from here, with my name and Brexpiprazole. And I tried to summarize when we should use Brexpiprazole. And we will see later when we should use Brexpiprazole, when Cariprazine. Well, the difference between aripiprazole is that Brexpiprazole is more sedative. So we know that when we give aripiprazole, some of our patients have insomnia, have agitation. For those patients, Brexpiprazole would be perfect because it's more sedative. It's more anxiolytic, and it's more sleeping inducing. This is due to the serotonergic pharmacodynamic effect. And so I say very clearly, this suggests that the use of Brexpiprazole should be preferred to specific subpopulation, decision treatment, targeted therapy. As an example, in subjects needing a low rate of activating effect. So I don't want to activate the patient. Aripiprazole may activate, could be useful, but maybe here I want to be more anxiolytic. And the cognitive functioning. Another interesting point is that the combination of serotonin 1A and 2A would explain the fast antidepressant and pro-cognitive effect, because you know that 1A and 2A are in combination in the synapses, and this would lead to a quicker effect of Brexpiprazole. Another very interesting point that I saw at that time, and I put in this paper, interesting results from mental studies suggest the combination of Brexpiprazole with SSRI improve the neurogenesis and inflammation. So it seems that Brexpiprazole, together with the antidepressant, indeed improves the pathogenetic basis of depression, like inflammation, and improve neurogenesis. So these are very interesting. But I also say no benefit comes without a price, because this benefit in terms of anxiety and sleep, of course, can lead to more sedation, more weight gain. Is a little bit more close to the pine, olanzapine, quetiapine. Is it good or bad? Depending on the patient. But it's very good, in my opinion, to have an aripiprazole that is a little bit more like quetiapine. And this is in between aripiprazole and quetiapine because of this effect. Very interesting, very useful. This is why we use it a lot. And indeed, Stephen Stahl puts a second point of treatment-resistant depression here after treatment. The last one is I wanted to discuss Lurasidone. Lurasidone is a little bit different from Cariprazine and Brexpiprazole Because lurasidone is a complete dopamine P2 blocker. And now we know that if we block completely the dopamine D2, something good and something better. Good, more control on agitation, positive symptoms, psychosis. Bad, risk of excessive demotivation, negative effect, negative symptoms. But there is a strong effect on 2A that counteracts this, and 1A. And 1,7 and a little bit on the 4. And how the famous gamma lurasidone? Lurasidone is put almost full in terms of bipolar depression. Nobody talks about lurasidone in unipolar depression, but we will see this next. Tolerability of lurasidone is very good. You have to be careful about this timing with food. Must be administered with food. In this meta-analysis, it is quite clear that the effect of lurasidone versus placebo in schizophrenia is indeed present. But it's more interesting to see that there is also a very strong effect on depression, bipolar depression. Those data suggested the use of lurasidone in bipolar depression. And the whole world now is making equal lurasidone, good for schizophrenia, but good also for bipolar depression. But let's see what happens for major depression. It is not mentioned much in guidelines. Well, in this very interesting study, they showed, it's not mine, in this study they showed that indeed the lurasidone in major depression could be useful more than placebo, but when? When you have a mixed episode. So the specific indication of lurasidone is not like Cariprazine or Brexpiprazole as an adjunct antipsychotic or antidepressant, but on the subpopulation of mixed patients that are the most difficult to treat, by the way. So we have something now that would be used for mixed. Why we don't give lurasidone to everybody? Because it would be too sedative for the others. For mixed patient, it's perfect. In fact, if you divide the sample in mixed and not mixed based on the Younger scale, in mixed the effect is much more relevant. So probably in the future it will appear on some guidelines, lurasidone plus antidepressant, in mixed unipolar depression, or with some signs of activation. In fact, the famous study puts lurasidone mainly in schizophrenia and bipolar depression, and they mention just treatment-resistant depression. I would add here mixed depression. And therefore, a couple of years ago, we did this paper that tried to summarize what I told you in the last 10 minutes, to summarize which is the specificity and how we should use each of these three different drugs. Lurasidone, Brexpiprazole, Cariprazine, whatever. In this small table, what you can see in the paper, we combine pharmacodynamic profile of the three with the specific activity of them. And therefore, lurasidone, complete block of dopamine, D2, and some serotonin, obviously is good for bipolar depression and for mixed depression, not for normal, I would say, melancholic depression. On the other hand, Brexpiprazole, good of course for schizophrenia, but for the depression that has more anxiety, irritability, or insomnia, I would say. For those patients, Brexpiprazole is perfect. And then we have Cariprazine. Cariprazine, then of course schizophrenia, it's important to know the differences to prescribe the right pharmacology. And so, each of the pharmacodynamic profiles that we have leads to different clinical effects. This is the last thing. Last 2 minutes of this presentation, I would like to give you a perspective in the future. I mentioned in the previous presentation the importance of the genetics. I would like in these 2 slides, we're not talking about genetics in this presentation in detail, but I would like in these 2 slides to give you an idea about how it works in practice. How can genetics in practice help our activity? This extremely recent paper, this is a book at present published now, we did something very innovative. I think probably for the first time in the world, probably similar to some one of the first times. We saw that some patients respond better to certain treatments depending on their genetic background. Let me explain a little bit better. You know that we have all genes for some disease. If we measure our so-called polygenic risk score here, we will have some of us that have a little bit higher polygenic risk score for schizophrenia, without having schizophrenia, obviously, but a higher genetic loading. Others would have less. Others would have a higher genetic loading for depression or for bipolar disorder. This is normal, even out of clinical populations, in normal people. We have different levels of liabilities. We saw that if we look at this liability that is not clinical, you don't see anything from interview, just from genes. If you look at this liability predicts response to specific compounds. And what was extremely interesting in this analysis is that if you have liability for schizophrenia, even if you don't have schizophrenia, just some liability for schizophrenia in your blood, you respond much better to antipsychotics. So, this means that if we take our 100 bipolar patients, 100 unipolar patients, and we do the blood analysis, we see that out of 100, we will have 10 depressed patients that have high score for schizophrenia. Even if you look at them, you see nothing different. Same symptomatology, same sleep, same everything. But underlying different genetic background. To those patients, if you prescribe antipsychotics, they improve much more. Because the antipsychotics go on a dysfunction that is there. Even if you don't see it. And the effect is not small. The effect is an strength of more than 2 for high polygenic risk score. And this other analysis, the same paper, I really like a lot. If you look at the response rate to patients with low and high schizophrenia risk, you see that giving the augmentation with antipsychotics to patients that do not have any kind of disease for schizophrenia, they are all depressed, remember, all depressed, but without any underlying disease for schizophrenia, there is not much benefit compared to standard treatment. If you give antipsychotics to patients that have a high polygenic risk for schizophrenia, similar clinical picture, they benefit much more in comparison. Much more. So, this is something that for the future could really change our activity, because we can see like beyond what we see with our clinical interview. And we could have then a distribution of the scores for all our patients. So, for example, we could have a bipolar patient that is very high in the scores for schizophrenia, but still is a bipolar. average in terms of bipolar and low in terms of risk of depression, then we will prescribe antipsychotics as maintenance. Better than treatment because the risk of schizophrenia is very high. If we had different scores, we could prescribe, remember the discussion we had at the end of the previous presentation, probably the patients that switch to mania after 10 years of antidepressants, they have a high polygenic risk score of bipolar disorder. We don't see them. We can also only measure by gene analysis. So, just 3 slides. This is not a presentation about genetics, but to what you can expect in the future. In your electronic health record, it can pop up information. Be careful. Your patient, John Smith, whatever, has a specific polygenic risk score. So think about it when prescribing. And then, if the score is like this, go more on the second generation. If the score was very low on schizophrenia, I would go to lithium. If the score was very high on MDD, I would go to lithium plus depressant, and so on. And then the final point, almost in time, consider that the nomenclature of the compounds that we are using is changing. There is this big initiative from ECMP, the MBN. You can download the app or the book for free. And I make it used to my residents because I think it's very useful to understand because it's not antipsychotics, antidepressant, but exactly the profile of the drug. So it helps much more in terms of clinical indication and use. Of course, it's difficult to change the names that we are used since more than 50 years, and that is also. So, the last slide, antipsychotics for depression. 20 years ago, we thought it was impossible. Now we see that for specific subpopulations, antipsychotics could be a good option for depression. It's important to choose the right one for the right patient. Otherwise, we don't give any improvement and we give only side effects. Okay, thank you for your attention. We can shift to questions.